How's it going, guys? Medium difficulty question for cardio step 1 internal medicine 2CK, 69-year-old woman, 4-month history of progressive shortness of breath with exertion, serum calcium 11 milligrams per deciliter, should be 8.4 to 10.2, serum protein electrophoresis, shows IgG kappa light chain spike. Question wants to know what's most likely to be seen in patients. So past level diagnosis of multiple myeloma with medium difficulty. Well, we're asking a bit of a different trajectory here as far as the cardio, okay? What do we see in multiple myeloma terms of cardio? Now, my last YouTube clip, okay, fine. So it was next best step in diagnosis for multiple myeloma, which is serum protein electrophoresis, showing the IgG kappa or lambda M protein spike, it's immunoglobulin light chains, and then you're going to go on to do a bone marrow biopsy for confirmatory is what USMLE wants, showing greater than 10% plasma cells in the bone marrow. Other findings, such as Bence-Jones proteinuria, urinalysis, blood smear showing clock phase chromatin and plasma cells, obviously pertinent, but USMLE doesn't ask those as concrete next best steps. You want the SPEP followed by the bone marrow biopsy. Lots of stuff we can talk about. Okay, high ESR, rouleau formation, but high MCV as well. I made my prior YouTube clip on that, but the point is, what are we going to see for cardio in multiple myeloma? So let's just hop to the answers here. Choice A, decrease endothelin expression, wrong fucking answer. So endothelin is a potent vasoconstrictor. 9 out of 10 questions, this is going to be referring to the pulmonary circulation, okay? So whether you have cor pulmonale, where you have a right heart failure due to a pulmonary cause, whether you have left heart failure that backs up to the lungs causing pulmonary hypertension, which backs up to the right heart, in any scenario of pulmonary hypertension, endothelin is increased in USMLE, okay? Students have been confused about this. OMG, really? You can see it in left heart failure? The answer is yes. Okay, there's an MBME question where they ask it. They want an up arrow for endothelin in left heart failure, as well as just any cor pulmonale, etiology, etc. 1 out of 10 questions, you can just be aware that endothelin can be expressed peripherally. There's an NBME question floating around somewhere where some dude cuts his neck shaving. So which the following would be seen in this patient's endothelin, increased endothelin expression at the site of injury, okay? So decreased endothelin expression, wrong fucking answer. Choice B, real quick, you should just know bosentan is a drug that is used for pulmonary hypertension. It antagonizes endothelin 1 receptors. As I already said, wrong fucking answer. Choice B, pulmonary capillary wedge pressure being normal, wrong fucking answer, okay? So you need to know that if you have any left heart pathology, it doesn't have to be overt cardiogenic shock where you have low blood pressure. Any heart pathology whatsoever, you're going to have an increased PCWP. So PCWP equals left atrial pressure, right? So here we've got, and I'll talk about the more specifics as we move through the question, but clearly we have progressive shortness of breath, which in the setting of a cardio question tells us more than likely we have left heart dysfunction, okay? So don't forget that left heart failure presents with pulmonary findings. You have a increased afterload on the left atrium. The left ventricle is failing, increased afterload in the left atrium, increased LAP, backs up to the pulmonary circulation, increased pulmonary capillary hydrostatic pressure, transitation of fluid into the alveolar spaces. That causes pulmonary edema, okay, sometimes pleural effusion, so that's your pulmonary findings, dyspnea. Right heart failure is going to be JVD, peripheral edema, okay? So normal PCWP, wrong fucking answer. Choice C, and I should mention that PCWP will be normal in cor pulmonale. That's a high yield answer for cor pulmonale. Okay, and I made many YouTube clips on that as well. If you had, let's say, cystic fibrosis, primary pulmonary hypertension, okay, idiopathic pulmonary fibrosis, and then you have right heart dysfunction, you need to know there's normal PCWP. Choice C, S3 heart sound, wrong fucking answer. 99 times out of 100, this is going to be systolic dysfunction. Okay, so dilated heart. It could be just history of high blood pressure, ischemia from diabetes, smoking. Okay, there's numerous etiologies. You could go down a rabbit hole of A, B, C, D, etc. Alcohol. B being beriberi for B1 deficiency. C, things like Chagas disease, cocaine. Okay, D could be drugs like doxorubicin. Okay, so lots of stuff we can talk about, but S3 is a dilated heart, dilated cardiomyopathy. 1 out of 100 times could be physiologic in pregnancy, could be high endurance athletes, S3. And I shouldn't actually, I'll backpedal a little bit. You could be aware that this is high yield for high output cardiac failure due to AV fistulae on USMLE. That's more 2CK stuff. You'll get a big fucking question. They'll tell you there's an S3 and an S4 heart sound at the same time. Holy shit. And they'll tell you there's some weird finding, like a pulsatile mass by the left ear. You're like, what the fuck? That's just an AV fistula, high output cardiac failure. S3 heart sound, wrong fucking answer. Choice D, S4 heart sound, correct answer. So S4 heart sound means a stiff left ventricle. Okay, so S4 is stiff left ventricle from increased afterload. S3 is dilated heart, often with increased preload. Okay, so S4, diagnosis here, multiple myeloma causing cardiac amyloidosis. NBME shows a nearly identical image. So you need to know that the more red areas, more eosinophilic pink areas in the image, that's going to be your myocardium. Then the more whitish areas, more translucent areas, that's supposed to be your amyloid. Now you say, well, I don't get it. What is amyloidosis? Okay, let's go back to kindergarten. Amyloid is protein. Now, amyloidosis means you have protein depositing where it shouldn't be depositing. Well, we said that multiple myeloma is going to be plasma cells secreting immunoglobulin light chains. Immunoglobulins are proteins. So those are depositing in the heart, causing cardiac amyloidosis, diastolic dysfunction, giving us an S4 heart sound. Heart can't expand. They deposit in the kidney. They cause renal amyloidosis. That's a nephrotic syndrome. Okay, so I've made various clips on this. I've talked about this in my cardio PDF with nearly identical image in there. So you need to know that cardiac amyloidosis, renal amyloidosis, most common cause in USMLE is multiple myeloma. Okay, and you're going to see apple green birefringence with Congo red stain. So multiple myeloma, you can also get it sometimes idiopathically, things like rheumatoid arthritis. I've seen that in a question. You could know tangentially / unrelated things like medullary thyroid carcinoma can have amyloid as well. Apple green birefringence, Congo red stain. So real quick, tricuspid regurg, wrong fucking answer. I can give you a very valuable piece of input here, which is the most common cause of tricuspid regurg and USMLE is pulmonary hypertension / cor pulmonale. Now that sounds really fucking weird because you say, wait, what? Why? Why not like pulmonic regurg? Great idea. Okay, great question to ask, but it's tricuspid regurg. So you'll get a question, any cause. It could be cor pulmonale, it could be left heart failure backing up to the right heart, and they'll tell you there's a 2-on-6 holostolic member that increases with inspiration, and that's just tricuspid regurg. Okay, due to the pulmonary hypertension. You would think things like IV drug use endocarditis would be high yield. They're not. I don't think I've ever seen a question on an NBME exam in history where IV drug use causing tricuspid regurg has shown up. Okay, you'd think that that's extremely high yield. Doesn't show up. Carcinoid syndrome, that has shown up causing tricuspid vegetations. Okay, that's when you have usually a bronchogenic or appendiceal small bowel tumor secreting serotonin derivative. High 5-HIAA in the urine that can cause tricuspid leaflet pathology, but tricuspid regurg, wrong fucking answer. You know the deal. To make more content if you like my stuff, subscribe my channel. Appreciate your time. That's it.